South by Southwest is going on.
Huh?
South by Southwest.
South by Southwest.
You never heard of it?
No, what's that?
It's like the biggest, like, a lot of artists, a lot of singers come there. It's like a huge Austin thing. Yeah, it happens once a year.
You going here?
Look it up. South by Southwest. It's
So I have highlighted there the radial nerve. And I want to kind of talk about that nerve a little bit, because it's prone to injury. I'll say it's vulnerable to compression. Can temporarily damage it. So I have it highlighted in purple. What I want you to see is that the nerve, it kind of starts in the front and then it goes to the back. I just wait for people to wander in. So I'm going to turn it around to the posterior view. Here we see it's on the back of the arm, which is why it innervates the triceps. However, because it starts in the front and goes to the back, right in the armpit area, the axillary region, it is vulnerable to compression. There's something called radial nerve palsy or Saturday night palsy. Forms radial nerve palsy because usually what would happen is you sleep in a funny way, or the classic example that's given is that you drink too much and you fall asleep in a chair with your arm slouched over the back of the chair like this, like in a drunken stupor, but your arm is compressing the nerve. That's how it goes from front to back. Then you wake up and it's like you lose mobility in your arm, your forearm, and it's called that. And I want to watch one more YouTube clip showing you an actual clinical case of it, and it's a really good one. And it gives students a rough idea of how doctors, clinicians assess patients. So it's good for you to see.
All right. So we're going to do this video. It's a teaching video. It ends up on YouTube, and you don't have any problem with it ending up on YouTube. You want your face blurred or not?
If you can blur you out.
I can blur you out.
Yeah.
Okay, we'll do that. So, do you want to tell the story of what happened to you?
I had a couple of drinks and fell asleep watching TV, sitting up on the sofa. Don't really remember where my hand was when I fell asleep. And when I woke up, it was
Doing that.
and I didn't notice it really until I went on the computer and was trying to use the computer.
When were you on the computer?
When I woke up.
Okay, in the middle of the night.
Well, no, it was whatever time I woke up.
Early morning hours?
It might have been midnight.
Okay, but you went to use the computer, and what did you find?
That it was, my hand was not working.
Okay.
And then I did my little test, you know, they say smile. Somebody could just send me that email too. I did the smile, I stuck out my tongue, and I thought, this is gonna go away in the morning, so I just went to bed.
Yeah, so you were making sure you didn't have a stroke.
Right.
All right.
And there was nothing else. Not my foot, nothing.
Yeah.
Not the other hand.
Very good. Very intelligent patient here. All right. Okay, so Joe, you're gonna do the exam. You're gonna demonstrate. So what's your working diagnosis?
So what we're thinking we have here is a radial nerve palsy and possible compression at the spiral groove. at the
Okay.
humerus.
All right.
And I think on physical exam we'll be able to show that that's what it is.
Okay.
So first, I'm just going to have you do some basic movements with your arm. Can you raise your arms like this? So you'll see it like, I mean, her axillary nerve, everything's intact. Can you take your arm and now flex it? Okay, can you extend it? Okay, hold your arm out for me and take your hand and just pronate it like that. So her pronation is intact.
Okay.
And then can you supinate it for me? Okay, and her supination is intact, but does it feel a little different when you supinate? Like, do you have any?
I'm feeling this muscle.
Okay. What we're going to try now is we're going to test for brachioradialis weakness.
Okay.
The radial nerve innervates the brachioradialis muscle. Can you hold your arm like this and then press up against my hand? So we did this test earlier, and it seems that she actually doesn't have much weakness in her brachioradialis.
Okay.
Now, as you'll see, when I hold her hand up like this, she actually has wrist drop. And
Okay. Now
that's-
try and we'll put both hands up together. Bring the other one over there for the camera, and now raise both wrists up. Flex both. Yeah. Dorsal. Okay. So you're unable to do that with this hand here.
Yes, can't do it with the right hand.
Now, what about extending the fingers? Can you extend those fingers at all? Okay, all right.
And
Very
you
good.
you can actually flip. Now make a fist. She's able to make a fist. Now come
Hey,
back
Chip,
up.
compare her grip strength though. Go ahead and
Yeah.
put both fingers now and compare that.
Squeeze as hard as you can. Grip strength is significantly decreased in the
It
brain.
is. That's what I found on my exam. Now, have her do abduction of her thumb.
Okay, can you take your thumb? It's like that now. Can you move it like this? What about with the other hand?
Yeah.
So no
Okay, so let's put
abduction.
both hands together. Now, let's try and abduct that thumb. That's as much as you can do.
Yep.
Okay.
That's
Now, what
crazy.
about sensory loss? You want to go over that,
Yeah.
Joe?
Now you told me earlier that you have some abnormal sensation in the dorsum of your hand,
Mhm.
arm right here, and then in the dorsum of your hand. But you're going in, but you have normal sensation
Pretty much, yeah.
here on the palm. Okay.
I want her to flex her elbow, flex it. Now, I want you to have her push you away with that. And what's your assessment of strength?
I'm gonna compare. A little bit stronger on the left side.
But her triceps are definitely intact.
Yeah, definitely intact.
Yeah.
So no diminished tricep strength.
So what nerve is it then that on the wrist? Go ahead and put your hand back down. What innervates this area right here? Hi, Dr. Penny. How are you?
So this is radial nerve.
So that's going to be your superficial radial nerve branch that is, and people with handcuffs will sometimes get damage to that, and they'll just have numbness. So it's a sensory nerve that comes out there. But you said her numbness actually goes from here all the way up. Is that right?
It's a neuropraxic injury, which means that the nerve is it's intact. It's just that it's been damaged from the pressure, and it'll heal. And it'll heal by something called axoplasmic flow, where protein will pass down. And that, when it does heal, sensory will probably come back before motor. So you start to feel tingling, burning. Some folks find it unpleasant dysesthesias, but that will pass.
Okay.
And then, of course, the motor. And then, of course, you've got to try to work with it. And therapy is going to be important. But we're talking months as opposed to.
Do you think it could be 6 months?
Yeah, 3 to 6, I would think.
Okay.
Yeah, depending on the degree of neuropraxic injury.
Anything else?
Good news, it'll come back, but it's going to take some time.
Okay.
Dr. Penny's a neurosurgeon.
That's what the nurse said.
Yeah. So he
said,
also
"I really
but
lucked out today."
he's also an emergency medicine doc. So
We're blessed that we can capture all this because it's a nice teaching tool.
Yes.
nice, that goes around the thumb.
Okay. And then this one. Don't let me get it too tight.
So you were saying you were trying to pay bills and use your left hand to operate the mouse. And that's when you kind of, and you were actually trying to pay bills because you were thinking
I
that
wasn't, I didn't know what
if
was
this
gonna
was a
happen.
stroke or something like that, you need to have those bills paid.
That's crazy.
So I want to give you a good example of how knowing this anatomy, it's important for when you get out there. You actually have to treat real people. There's a lot of things mentioned there. I mean, they did a lot, and we haven't covered everything, but I think you should have picked up on it. Say, oh, that's how he tested for strengthness. It was like he was pushing down, okay, come on, try to lift your shoulder. Why is he doing that? He's trying to test muscular strength, and he mentioned raise your shoulder, and he's testing the axillary nerve, because what does the axillary nerve innervate? Deltoid. You're still trying to remember it, but that's why. And then he tried to have her like extend your elbow. He's testing the triceps. You should know that, I just talked about it. So, because the radial nerve, and not just innervate the triceps, it's going to go all the way down and innervate all these muscles here. So he's testing at every part, because basically, if you got okay triceps, that means the compression happened distal to it. So that's why they do the analysis. And that's why it's like, they also did the numbness, because that's sensory, right? And based on how much is numb, you could tell things too. Remember he said a thing about the handcuffs? He said, oh, usually it's just this part that's numb. But he said, oh, this patient, the numbness was all the way up here, so the compression was further up. So there's cutaneous, but then there's motor. We're not doing the cutaneous. We're doing the motor, okay? What was else? Oh, you should write this down. When he said wrist drop, I think that was the most significant thing in that case. Wrist drop. See if I have that here. Slides on wrist drop. Can't find it. Oh, I think it's on another slide. Hold on a second. Just bear with me for 1 second. Yeah, I'm on the wrong file here. So I think this is very clear on the video where you had to put the hands side by side, but you could do this with one hand but not the other. Because this just looks natural. Oh, she's just doing that. She couldn't extend it. So that's called wrist drop. That's the main problem she had. I want to show you that picture. And we also learned how that nerves can heal, right? Called the neuropraxis injury from compression of the nerve. And how many months did he say it would take to heal? 3 to 6, right? And he mentioned, did you catch axial plasmic transfer? That's where it's like the cell. You know where the cell bodies are, right? They're not out here. They're in the ventral horn. And the cell bodies are there in your spinal cord. Over time, the transfer of the proteins will go all the way down and heal the axons, and eventually it'll come back. Maybe sensory first, then motor. So you picked up a lot in that one little clip. You also see how people work together. You had GQ Joe. What level was he? He was the med student, right? But he can treat patients. He's good enough, right? But the guy making the video who we couldn't see, that's the guy. He's probably the attending or whatever, the resident but clearly he had more knowledge, right? And he kind of pressed Joe, oh, which nerve is it? And Joe said radial nerve, but he didn't know the branch, right? So you don't have to know the branches either, but I'm just trying to get you to see. Then the neurosurgeon walks in, right? And he has his own expertise. So that was a good video for you to see how teams work. I guess someday you'll be a part of some team. And yeah, how exciting. Let's see here. Okay, so I did radial nerve, and I want to continue on with some more muscles. And I think as a group, the next group I'll do, I did kind of the big muscles of the arm, basically bi-tri and brachialis. I want to do muscles of the thorax. There's not too many. As a group, these are muscles in between the ribs, and those are called the intercostal spaces. So this is the intercostal muscle. This group is known as the let's do this one. This one. The internal intercostals. Let's do that one. Let me pull back. Got to highlight it on one side. The internal intercostals. What I'm writing is that all intercostal muscles occupy the intercostal spaces. And for all intercostal muscles, the innervation is easy to remember, just intercostal nerves. Remember, NN is my abbreviation for nerves, plural. And intercostal, what does costal refer to? Ribs. And notice that this muscle group, it goes all the way to the front, all the way to the sternum medially. Okay. Let's isolate them so you can see how far back they go. It goes all the way front to back. Isolate. There you go. There's kind of a view from the back. So do they go all the way to the spine? No. But they go to the back, just not all the way to the spine. They kind of end around here. Okay, so basically the attachments for the internal intercostals, think of it as, well, let me explain the action first. They basically will depress ribs. Usually when you take a breath out, your rib cages collapse. That's depressed ribs. Usually that's a passive process. Only like when you're huffing and puffing do you actually have to activate these muscles to actually depress ribs. So just remember that. Helps depress ribs. So think of it as each rib is pulling the rib above it down. So the whole thing collapses. So the origin is the superior border of a rib. Then the insertion is the inferior border of the rib above. Okay? The origin, superior border of a rib. So then the insertion is inferior border of the rib above it. So there's also an external intercostal. Right there. So I'm going to keep the internal intercostal highlighted with the external intercostal over it. A couple of things to notice for external intercostal. as a muscle group? Well, I'll ask the obvious question first. Which one's more external? The external one? I mean, it's superficial, right? Also look at the crisscross of the fibers. See how the internal ones are kind of like running that way, but in this one they're kind of running that way. So when they intersect, you can kind of see a V. I always look for that. And so when I kind of tag these muscle groups, I'll kind of tag one or the other, try to pay attention on a cadaver. It'll be easier to see these are external to this. So let's isolate the external intercostals. Highlight them, ISO. Now these don't go all the way to the front, do they? I mean, they go a little further back, okay, than the internal ones do, but basically they don't go all the way to the front like the other ones. So these do the opposite. If those depress ribs, these elevate ribs. I would say this muscle group, external intercostals with the diaphragm, those are your main muscles of inspiration. So external intercostals plus diaphragm. Main muscles of inspiration. Is inspiration a breath in or a breath out? Inspire, inhalation. Okay, expire, exhalation. When you're inspired, metaphorically, when something goes into you to inspire you, it's the same thing. You breathe air in. So remember that elevate ribs, that one depresses ribs. What's the innervation? Intercostal nerves, right? The origin insertion is different because you now elevate ribs. So the origin it's like the inferior border of a rib, and the insertion is the superior border of the rib below. Insertion, superior border of rib below. Just the inverse of that, basically, to depress ribs. Okay, well, let me go back and get out of there. Let me see if I had anything else listed for thoracic muscles. One other, anterior scalene. So the anterior scalene, I don't care that you know the attachments or anything like that. I wanted you to know it because it's a landmark to locate the brachial plexus. That's why I wanted you to know it. I will mention it attaches to first rib, but it's used as a landmark to locate the brachial plexus. I mean, basically what you see there, the rami converge posterior to it, the ventral rami. Today's quiz. How many? 5. Ventral rami emerge, I think I mentioned this before, posterior to it. Okay, so that's that. So I called this as a group, I don't know if I wrote it on the board, muscles of the thorax. For those of you who use the atlas, you got to go to the thorax region. Let me get the page number here. Yeah, there's pretty good pictures on, starting on page 62, 60, 63. In the atlas have good pictures of thoracic wall muscles. Any muscle that attaches to the rib could be considered it, but in terms of breathing, any muscle that attaches to a rib could help you breathe, and they call them accessory muscles of breathing, but we won't get into that right now. It's okay. I want to move on, and I want to move away from thoracic wall and go down to the forearm, okay? And the forearm basically has two parts. There's a posterior compartment and an anterior compartment. So think of it that way first. And let's remember that the anatomy word for forearm is antebrachium in two compartments. Posterior compartment. Basically, if you're a muscle on the back of the forearm, you're in the forearm, but what do you move? You're going to cross wrist and digits. You're going to move wrist and digits. But if you're on the back, do you think you're going to be a flexor or an extensor generally? You're going to extend stuff if you're back here. So think of this as an extensor compartment. There are exceptions, but basically it's an extensor compartment. Then you have the anterior compartment. We studied the physiology of it in the Clinch experiment. So when you clench, that's basically flexion of things. So the anterior compartment, you mostly have flexors, generally speaking. There are some other generalities. I want to do the posterior compartment first. Let's take a look at it. Let's go down to the forearm. Let's go to the posterior view. Let's add some muscle layers. There you go. I'm all there. I gotta say the forearm of all this stuff, it's probably the most difficult in terms of identification because there's a lot of muscles and they're packed tight and they're slender and they're all right next to each other. So there's a lot of study that you have to do. Well, in case you haven't figured it out, yeah, there's a lot of studying for this whole unit. A lot of material. So we'll do the posterior compartment first. So these are mostly extensors. As a category, how they move stuff, you're going to have a lot of muscles that either extend wrist or adduct wrist. Abduction, adduction. Okay, that's how they might move the wrist back here. They'll have muscles that extend or abduct thumb. And muscles that extend digits. Well, the rest of them. Thumb is 1, so the rest of them will be 2 to 5. Okay. So mostly extensors, but I have to mention all the other things too. And the other thing is, they pretty much all originate from the lateral epicondyle, mostly. I'll highlight, like, say, the first one there. posterior compartment, isolate. So if I look at this, see how they're all coming from one side? Well, just to orient you, if you missed what I zoomed in on, this is medial. I don't see any coming from there. They're all from this side. So they pretty much all originate from the lateral epicondyle. The other thing that is true for all muscles in this compartment is radial nerve. Served by radial nerve. How many muscles are we talking about here? 9. And it helps to even think of them in groups of 3 for the 9. The first 3 I'll talk about. Let's do this one. This one. That one. Okay, those 3 muscles right next to each other, I'll highlight the first one. That's the brachioradialis, and the next 2 are also radialis muscles. So the first 3 I'll talk about are radialis muscles. Well, because you start there and they're all on this side. And when I study cadavers, I always name them in order, okay? And I'll try to name them in the same order as I lecture through them. We'll start with that first muscle I've highlighted. It's the exception muscle. It's the brachioradialis. We'll isolate it. Exit that, isolate. The big forearm muscle, brachioradialis. So this muscle is named for its attachments, origin, insertion, okay? And remember that, because you always misname this muscle. I've seen every derivation of this term. The most common one is radiobrachialis. You so want to say that. Maybe it's because I tell you call it that, so oh, you get stuck in your head, oh, I shouldn't have even put it out there, now it's in your brain. It's brachioradialis, okay? Which one do you think is the origin? The brachio or the radialis? The brachio first, right? So the origin on the arm, lateral epicondyle. That's on the humerus. It inserts the styloid process of the radius, brachioradialis. So I'm going to zoom in on styloid process of the radius. So I got it zoomed in there in the styloid process. See where it inserts. Here's a question for you. Does it cross the wrist joint? The answer is no. If it ends here, it doesn't cross it, and therefore it can't move the wrist. Can it move the elbow? Yes. Okay, the main action of this muscle is elbow flexion in mid-pronation. Now, why is that? You know what elbow flexion is, but why the mid-pronation thing? Okay, what's pronation again? If this is supination, full pronation is you completely turn your hand over. So if you turn your hand halfway, that would be mid. And then you flex, like drinking beer, right? They call this the beer drinking muscle, right? Because, you know, that's what you do. When you drink, you don't hold the glass like this. You mid-pronate and then drink, right? Well, I guess really, you ever do hammer curls? What's a regular curl? Like you just curl like that? Hammer curl is like that, like that. So maybe they're a little bit easier. Probably because you're getting more force from the Brachioradialis, okay, for you weightlifters there. So there you go, elbow flexion, you just remember that. It can elbow flex in any angle. It does it best in mid-pronation, because look where it is. It inserts laterally. So if you kind of go like that, it can flex better. Now, I said this is an exception muscle. Why? What's the exception? This compartment are extensors, but not this one. Okay, I guess that's the exception. It doesn't move the wrist either. It is innervated by radial nerve. On cadavers, this nerve is underneath, literally underneath the muscle. That's where I look for it.
What did you say the exception was? I'm sorry.
Okay, what action does it do?
It just does the
It flexes.
effect.
And what did I say all other muscles do in this compartment? Extend, yeah. So it's usually taught in this compartment, so that's why it's called the exception. It's an important one. Because once I find that one, I just name all the muscles after it, all 9 of them. The next one next to it is extensor carpi radialis longus. Extensor carpi radialis longus. First word, extensor. So you know what it does. It extends. But then you got to get the next word right. What does it extend? Carpi. Carpi, carpi. Let me see how they say it. It's the wrist.
Extensor carpi radialis longus.
Yeah, they say carpi. I've always said carpi. Extensor carpi radialis longus. The hard part about naming this muscle is this 4 words. You got to get them in the right order. I will not accept it if you miss a word or if you put them in the wrong order. You got to get all 4 words right. It tells you a lot by the name. You know it's an extensor. You know it extends the wrist. So you know what side it's on. You have a radial side and an ulnar side. So it's not on the ulnar side, and it's long. Compared to what? There must be a brevis. Okay, so you see it there. I mean, the origin and insertion, we'll just keep doing it. Origin, lateral, epicondyle, insertion, base of the second metacarpal. Let me zoom in on that so you can see it. So see the tendon terminating on the base of that bone. That's first, that's second metacarpal right there. Okay, so that's a clue too. I mean, it helps me identify. When I try to identify this muscle, I look for it to point to this digit. I kind of follow it to this digit. So this muscle extends wrist. I shouldn't even have to write it. It's in the name. Okay, but I'll just write it. And I won't write the innervation anymore. What is it? Radial nerve. Yeah. It's all the same. So let's do the next one. So pretty much the brevis is deep to it. It's hiding in there. Right? There. Got it. Isolate. Let me tell you another rule in anatomy, generally speaking, okay? Just generally speaking. Let's say you have any joint. So they have to cross that hinge joint that I'm drawing. And here's a muscle crossing the joint. And here's another muscle crossing the joint. Which muscle is longer? The one more superficial or the one deeper?
Superficial.
The one more superficial. Well, it has to be, doesn't it?
Right. It's longer.
So that's generally what you see. Longest muscles are usually more superficial because, well, they have to be. Okay, that's what we see here. It goes longest, then brevis. Okay, in terms of the order. So, sensor, carpi, radialis, brevis. Another confusing thing in anatomy is kind of the USIS thing. It's longus, but it's brevis. Now, if you look at the origin, it's the same. I won't even list it. It's all lateral epicondyle from here on out, and pretty much go follow it down. Get the hand in the picture there. Which metacarpal is that muscle inserting on? Digit number 3. So the insertion is different. Base of third metacarpal. That's the only thing that's different. So you don't freak out if like, oh, that's the only thing you put. Oh no, oh no. What does it do? What does it do? I don't know. What does it do? Extend wrist. What's the innervation? Radial nerve. Okay, so it's easy when it's the same for all. Maybe you want to write it down because you feel you'll forget. But don't sell yourself too short. It's all the same. Okay, so those are the 3 radialis muscles. There's 6 more. This next one's a biggie. They move with adductor pollicis longus. All right, this next muscle is abductor pollicis longus. Draw a line. Next 3 muscles. The next 3 muscles all move the thumb. What is pollicis? Which digit is that? Thumb. And abductor tells you what it does. This muscle abducts the thumb. Okay. The origin, it mostly grabs. There's a membrane in between the 2 bones. It's called the interosseous membrane. So this muscle originates on that membrane between radius and ulna. Okay. So I'll list that. as the origin. The insertion, if you follow it down, it's right there. It's the base of the first metatarsal. Metacarpal, sorry. Base of first metacarpal. Metacarpal. That is, so that when the muscle pulls on that joint, it's going to abduct the thumb. Let's look at that. Remember, that's movement in the sagittal plane there. See how it's pulling the thumb out that way in that sagittal plane? That's abduction of the thumb. Yeah. Innervation, radial nerve. So that's an abductor. The next muscle is an extensor. It's the extensor palsus brevis. Extensor palsus brevis. Oh, isolated. There it is. The same origin, interosseous membrane. And it inserts on the proximal phalanx. If you follow it all the way down, that was in there on it. So it's inserting on the proximal phalanx of digit 1. I'll say palms. That's the thumb. Let's look at extension in terms of motion. There we go. Movement in the frontal plane, basically. Right there. That's extension. That's flexion. Right there. And then this is extension out there. So flexion of the thumb, extension of the thumb. There you go. So which one does this muscle do between flexion and extension? Extension, right? And so if you remember the name of the muscle, and it's like, there is a flexor, and I don't even know if I'll get to teach it. It's too deep, but at least you know the extensor. The silly mistake on the test is, if you remember and name it correctly, the extensor palsus brevis, and then tell me it flexes the thumb, that's silly, right? The name implies it doesn't do that.
Right.
So that's kind of the one that frustrates me. What? It's an extension. You said it flexes. You know, there are muscles that can flex and extend, but if the name is an extensor, then that's not true. Okay, well, there's another one. This one also moves the thumb. This is the extensor palsus longus. Isolate. It's longer. Well, if the brevis went all the way to the proximal phalanx, where do you think the longus goes? To the distal phalanx. Okay, before I don't want to erase it. Let me just draw it here. Extensor palsus longus. So, originates interosseous membrane. Inserts distal phalanx of pollex. The action is to extend the thumb so it can move that distal joint. So this can extend, well, okay, let me just tell you how to remember here. So they go in order here. So it's like, let me get it back in the picture there. It's really difficult to visualize them. There's 3 tendons here. That's the first one. That's the abductor pollicis longus. We can see the tendons, not the muscle, because they're hidden by the other extensors. This next one is extensor pollicis brevis, and this next one is extensor pollicis longus. So notice the pattern. It goes abductor, then extensor, extensor. But then notice the longest thing. It goes longus, brevis, longus. Okay, so that flip-flops. So it goes abductor, extensor, extensor, then longus, brevis, longus. Let's backtrack just a little bit. Let's go back to find our landmark muscle, Brachioradialis. What came after that? 2 extensors. The first extensor was a longus, extensor carpi radialis longus, extensor carpi radialis brevis, and then the 3 muscles that move the thumb. Abductor pollicis longus, extensor pollicis brevis, and then this tendon of the extensor pollicis longus. So if you go all the way back up to those 2 wrist extensors, it always alternates. It goes longus, brevis, longus, brevis, longus. If you practice that, you'll see the longus, brevis thing, they always alternate.
Okay.
There's no easy way to do it. I'm trying to make it easier. So those 3 muscles move the thumb. And there's 3 more muscles here. This is the main extensor of the digits. Let's isolate it. It's called extensor digitorum.
And these are the ones that move the digits?
Yeah, they extend the digits. Let's look at finger extension. So that's what it does. It extends digits. So now we're going all the way back up and originating from the lateral epicondyle. Okay, I'm just going to come all the way down and can't see it there. It's going to insert on the distal phalanges of digits 2 to 5. When it extends, you'll see it comes all the way down to the distal phalanges. Originates lateral epicondyle. Inserts distal phalanges of digits 2 through 5. Not 1. 1 has its own extensors. Right, so this does all the other ones, digits 2 to 5. So I'll extend the digits. And tell me what the innervation is. Same nerve.
Radial?
Radial nerve. Oops. Let's go back there. And let's do the next one. The next one's a small one. So the action, to finish this one off, is extend digits 2 through 5. Now you have other extensors. This is most of them. You have one more extensor. It's called extensor. Yeah, digity mini me. Let me try if I can get into there.
Extensor digiti.
Now the correct pronunciation is extensor digiti minimi, but I like to say digiti minimi. I don't know why it's just funnier that way, but it's a slender muscle. It's hard to see. It's hard to teach it because it's so slender and difficult to see on the app. Extensor digiti minimi. So obviously, what digit is that? You know, digit 5. So I'll start with that. Extends digit 5, hence the name, digiti minimi. But it's originating all the way back up there at the lateral epicondyle. It's going all the way to the distal phalanx of digit 5. So I'll continue over here. It originates lateral epicondyle, and it basically inserts distal phalanx of digit 5. There's one more muscle here. It's the 9th one. Extensor carpi ulnaris. So again, I'll start with what I think is the obvious. What does it do? It extends wrist. And you can tell what side of the forearm it's on. Not the radial side, the ulnar side, the ulna bone. Okay, now it still originates on the lateral epicondyle. That's still lateral epicondyle, but it kind of crosses over to the ulnar side. And it's going to insert, it's hard to tell with fingers missing, inserts on the base of the 5th metacarpal. Originates lateral epicondyle. Inserts base of 5th metacarpal. So a lot of these insert on the metacarpals, right? The extensor carpi, radialis, longus, and brevis, those inserted on like 2nd and 3rd. You have Dr. Paulus's one inserted on the base of the 1st. This is like inserting on the base of the 5th. So those metacarpals are for attachments. So that's all it does. It extends the wrist. The innervation is still radial nerve. And so those are the 9 muscles of that compartment. Now if you turn around to the front, there's a lot more. We're going to do 5.
The interior.
call it 4+1. Let's go with that. I don't know if you can see there. You see how there's 4 muscles side by side there? This is the superficial group. Or the front of the arm. And I want you to know 5 muscles. Know 4 in the superficial group. Know 1 muscle in the intermediate group. There's a deep group, we're not doing it, okay? You'll thank me later. Now, why do I do and not do? It depends on what I have to show you. Generally, I just try to show you what I can show you on a cadaver, okay? And the rest I just don't do it. I used to do the deep group when I had that arm. Now I don't because they took it. So anyways, those are the 5 you gotta know. So the first 4 in that first group. Now, an easy way to remember where these originate from is I take my 4 fingers, because I got 4 in this first group, and I go like that. That's kind of how they look up on there. And which epicondyle is that when I go like that? The medial one. That's how I always remember when I review my notes. They all originate. From medial epicondyle. Because I can't do this on the lateral one. I can't even do it. So I say, okay, good. That kind of has how the 4 look. And also, it's not the radial nerve anymore. It's going to be either median, mostly median nerve, but some muscles are ulnar. So, median ulnar nerves serve this area. All right, the first one, if I do my 4 fingers, the first finger kind of goes across my forearm. It's the pronator teres. It's isolated. Teres means round, but by its name, you can tell what it's going to do. It has an insertion on the radius. It's going to pronate. Well, let me animate that for you. There's pronation. Right there. Pronator teres. So that's another one. It's like, oh, I can't remember what it does. If you remember the name, a lot of these muscles are named for their action, right? You have a muscle called supinator. We're not doing it, but that muscle supinates. This muscle is named for its ability to pronate. Pronator teres pronates. Pronates the forearm. You don't have to say pronates the forearm. There's only one thing in anatomy that we talk about pronation and supination. It's the forearm. That's it. So just say pronates in terms of its action. Now its origin, it's going to be, I just wrote it. I don't know where I wrote it. It originates from medial epicondyle. It's going to insert about mid-shaft radius. Inserts mid-shaft radius. It's the pronator teres. Let's go look at the next one right next to it. It's a flexor carpi radialis. Okay. Well, anyways, it's on the goes all the way. I usually say that it inserts on the base of the second metacarpal. It looks like it has it on both. I'm going to go with the second. It inserts on the base of the second metacarpal. Flexor carpi radialis. It inserts base of second metacarpal. I'm not writing the origin down. Where is it? Medial epicondyle. Don't forget that as I go through the details here. Here's a full view of the muscle. And I should give you a page number for these anterior posterior compartments. Mostly talked about. Oh yeah. If you go to 332, that's pretty good. Good page references 332 to 340. Yeah, thanks. Well, these first two I did, the innervation's median nerve. Okay, let's do the other two. Let's do, after that, palmaris longus. Palmaris longus. The palmaris longus is not always there. Oh no, I forgot to mention action for this. But it is in the name, named for its action. So what will it do? Flex what?
Flexor it.
Okay, palmaris longus. Okay, let me isolate the palmaris longus. It's a very slender muscle. There is a palmaris brevis too, but we're not doing it. It originates medial epicondyle. And it basically will insert, not on bone, it's going to insert on a structure called the palmar aponeurosis. Let me kind of show it to you. This is not in the picture here. Let me insert connective tissue. There it is. So what I have highlighted in green is the palmaris, palmar aponeurosis. Let me do a multi-selection here. It's kind of hard to see. Isolate. So the yellow tendon is of the palmaris longus. It inserts, it's continuous with the palmar. Aponeurosis. And aponeurosis is not, it's not skin, it's not muscle, it's connective tissue. Okay? And so what this muscle can help do is when it tenses the palm of skin. Okay? It can flex the wrist. That's its action. And also tense skin of the palm, okay? Kind of, it's named for pretty much its insertion on the palmar aponeurosis. It's continuous with it. I've read it's absent in 14% of people. Now the tendon is very visible. I can just kind of flex, kind of move my wrist around. Oh, I got one there. Do I have it on the other side? Oh yeah, it's there too. I've seen cadavers where it's like missing on one side. It's like, what the heck? That can't be right. Well, it could have been somebody removed it, but you can look to see if yours is there. Okay. Palmaris longus. Remember, that's the one that could be used for an tendon autograph. Okay. And the UCL reconstruction. The last muscle here in the superficial group is the flexor carpi ulnaris. Flexor carpi ulnaris. We isolate. Pretty big muscle. Flexor carpi ulnaris originates in the same place. It's going to insert the base of the fifth metacarpal. Now we also had an extensor carpi ulnaris. Did insert it on the base of the fifth metacarpal, but you know, this is the flexor one. So is it going to be on the anterior aspect or the posterior aspect? The anterior aspect. The extensor would be on the posterior aspect, both on the base. Okay. Well, anyways, what does this muscle do? It flexes the wrist. You can do other things, but let's just stick with the easy ones, okay? Look for it on the ulnar side of the forearm. Okay, that's illustrated there. Now, the innervation is different. I'm going to go back to palmaris longus. Palmaris longus, the innervation was still median nerve, this one. Now, it's called flexor carpi ulnaris, and you have an ulnar nerve, right? It's on this side. So the innervation is ulnar nerve. So far, these four muscles that I've covered, let's review. If I go like that, my first finger is pronator teres, my second finger is flexor carpi radialis, my third finger is palmaris longus. They're all median nerve, but my fourth finger is this one, flexor carpi ulnaris, and it's the ulnar nerve. Okay? Let's do the next muscle, flexor digitorum superficialis. It's a deep muscle here, so I have to remove a muscle layer to see it. Let me isolate it. Flexor digitorum superficialis. Yeah, you're right. So this is the only muscle in the intermediate group.
Oh, so we're going to intermediate group?
Oh, yeah.
Sorry.
Done with superficial. How many in the superficial group? Four, and we just did them all. Didn't we?
Yes.
I'm counting, yeah. Call it FDS for short. You can use that as a memory jogger for flexor digitorum superficialis. I'm gonna start with its action. Flexes digits 2 through 5. You have a flexor pulse as long as we're not doing it because it's in the deep group. But these we will do. We can see it in our cadavers. And I kind of zoomed in where it inserts. It's going all the way. Here's the proximal. Here's the middle. Here's the distal. But it ends right there at the middle phalanges of these digits. So I'll start with the origin. It has a lot of origins. Let's just stick with medial epicondyle. Inserts middle phalanges of digits 2 to 5. So you have to think about which joints it can flex, because I showed you all the joints. It crosses the wrist. This muscle can flex wrist. That's a joint. It can also flex your knuckles. That's the MCP. You can also flex PIP. Okay, that's kind of like here. Okay, when I'm doing now with my little finger, that's the PIP. Now it cannot flex the DIP. It can't do this. You have another muscle that does that. We're not doing it. That's the DIP. But it does all these. Okay. It cannot flex. Emphasis on cannot flex the DIP. The muscle that does that is the deeper one. If there's flexor digitorum superficialis, that's a relative term. The one deep to it is called flexor digitorum profundus. To be profound is like you're deep. That's why they call it that. But anyways, you don't have to worry about that one. Don't worry about this one. The innervation, median nerve. Okay, that concludes the muscles. Well, let's talk about next week, because next week I won't lecture much. I'm just going to mostly present cadavers. Turn off my